Good afternoon, everybody. My name is Rick Grindrod, and I am the CEO of Provider Partners Health Plan. And I have the unenviable task of talking about trying to improve quality in our facilities in the midst of what might be the worst nursing shortage in a generation or more, right? So to get started, let's talk about that shortage. How many of you are experiencing staffing shortages? Everybody? Jeez. All right, well, you're one of the 94% or 81% of facilities that back in June reported staffing problems. And I think it's pretty clear that COVID vaccine mandates have just made the situation worse, right? And so we're struggling to have good quality staff in our buildings, to find them, to keep them, and keep them taking care of our residents. Are all of you long-term care, skilled nursing facility management? Is that everybody in the room? Okay, no assisted living? Oh, a couple of assisted living? Okay, great. How about CCRCs, retirement communities, other kinds of senior living? Yes? Okay. All right, very good, very good. All right. And there's some long-term causes for this, one of which is back in the day, not many of you are old enough to remember this, but I remember back in the day there were baccalaureate nursing programs, right? And so those programs through hospitals and community colleges pumped out RNs who had real good hands-on skills, and we could count on them to do a great job of taking care of our residents back in the day. Well, those RN programs have almost all gone away. And so there are 80,000 qualified applicants out there applying to nursing schools who don't have a place, that the schools don't have a place for them. So it is a challenge. Now, interesting on this map, the light purple represents where the crisis is the worst, right? So California, Nevada, Texas, South Carolina. Here in Missouri, I don't know what y'all are talking about. Here in Missouri, there's no problem at all. There's plenty of nurses. That's the national statistics anyway. So at the same time as we're experiencing this nursing shortage, we're also experiencing a big push in all of healthcare, right, for more value-based care. Instead of paying us according to how much we provide, the entire Medicare system is shifting to value-based. What are the outcomes, right? And so there's ACOs and bundled payment programs. Anybody participated in a bundled payment program? Nope. Okay. Oh, one. All right. As I said, ACOs, bundled payment programs. Now there's a new program called direct contracting entities. Anybody involved in a direct contracting entity? All right. But the old tried and true version of value-based purchasing, value-based care is Medicare Advantage. Everybody knows what a Medicare Advantage plan is? Yes? Yes? Okay. So Medicare Advantage takes the place of Medicare A, B, combines the two of them into Medicare C, or Medicare Advantage, right? And then also includes the prescription drug plan. And PPHP, the company that I run, is a Medicare Advantage plan, right? And so those Medicare Advantage plans include all of the community-based Medicare Advantage plans, right? And then there are also a few special needs plans for Medicare beneficiaries with chronic diseases, special needs plans for Medicare beneficiaries who are dual eligible, And then there is a special designation for Medicare Advantage plans that specifically focus on long-term care residents, right? And those are called institutional special needs plans. And that's what my company is. And we enroll specifically just the long-term care residents of your facilities. Anybody have any experience with an institutional special needs plan? One? Which one? Optum. Okay. All right. PPHP? All right. Are you with HSI? Okay. Very good. Very good. Excellent. Excellent. Well, thanks for being here today. So institutional equivalent special needs plans are those plans that serve residents of not of nursing homes, right? Not of long-term care facilities, but of assisted living facilities and senior living apartments and some residents living in the community who have special needs that are being met in their homes or in the assisted living facility. Otherwise, they would have a long-term care level of care, okay? So that's an institutional equivalent program. So we started the company in order to try to harness what was good about special needs plans without getting too far into being a major insurance company. And so we got approval from CMS to operate our plan. I have 30 years of experience operating a long-term care facility, an assisted living facility, and a retirement community out of Baltimore. I worked for Erickson Retirement Communities for a period of time for the first 25 years of my career. And what we did there and what we've done here is focus on building a model of care around the residents, right, that provides a better quality of experience for them. And what we discovered is, as we did that, we reduced the incidence of hospitalization. There was significant savings to the overall system, right? And Medicare, given all their savings, never even sent us a thank you note, right? So we invested in electronic medical records. We invested in nurse practitioners. We invested in care coordinators. And really put this entire model of care that I'll show you in a minute around the residents. And there were significant savings, right? And we didn't benefit as an organization from any of that savings. So we launched what's called a provider-sponsored health plan, right? And this is the intersection of insurance and provider, right? And this is what gives us the ability to harness those Medicare dollars for the benefit of your residents. Okay? All right. So when we started this process, we met with Optum, we met with Cigna, we met with smaller insurance companies, Gateway. We looked around, we met with Aetna, and we said, we want to take responsibility for the 85 cents of the healthcare dollar that the Affordable Care Act requires is spent on the provision of care, right? We want to take responsibility for that. And you, the big insurance company, can keep the other 15%. And they were not interested in doing that. Optum wouldn't do it, Cigna wouldn't do it, nobody would do it. And so we launched our own provider-sponsored health plan. And our whole goal is to build this model of care with our long-term care partners, with HSI, for example, so that we can reduce the incidence of unnecessary hospitalization, create that savings, and return that savings to the nursing facility to be spent on whatever the things are that the nursing facility really needs the most of. All right? So how can an iSNP help with the nursing shortage? So the first thing we do is we add clinical staff right there to your building. All right? We bring in a nurse practitioner and an RN care coordinator on site. If your building has 50 or more residents, that RN care coordinator and nurse practitioner are there every day, right? They're there every day to work with your director of nursing, to work with your charge nurses, to work with your clinical team on taking care of the residents. That nurse practitioner in our program, and there's a variety of provider-sponsored iSNPs, but in our program, that nurse practitioner is on call 24 hours a day, 5 days a week, and then one of the nurse practitioners from our program in the area takes call through the weekend. So you always have a PPHP nurse practitioner at your beck and call 24/7 to assist you in determining those clinical issues and how to best treat them, right? The RN care coordinator, she's somebody who helps navigate through the complex insurance system that CMS has set up so that you don't have to take your staff time in figuring all that out, all right? The second way that we help with the nursing shortage is with remote patient monitoring, all right? So one of the worst things that I experienced when I was a nursing home administrator is that nurse health department surveyor, right, who spent 6 hours combing through your medical record of a patient. And she comes up to you and she says, Rick, did you know that whatever sentence comes after, did you know, is never good, right? Is never good. Did you know that Mrs. Jones had swelling in her ankles that was documented by your nursing assistant for 4 days before somebody did something about it? Did you know that Mrs. Smith's family was complaining about a cough that she had for a week before it's documented that anything was done about it? Did you know? And you know what? You can't know. Your team goes through those medical records. They do as much as they can, as often as they can, every single day, but things slip through the cracks. Am I right? Right? And so that whole did you know thing just sends a shiver down your spine. So we have this proprietary technology called RealTime that goes in over top of the medical record, and all it does is data mine out key words and phrases, key things that are documented in that record, and compares them to a hit list that says if one of these things exists, send up a flag and send a notice to whomever you ask. The PPHP nurse practitioner, the PPHP RN care coordinator. If it's it can go to your DON, your administrator, your nurse manager. And what that flag does is it identifies for you that there might be something going on with that resident, right? So let me go back to the example of the swelling of the ankles and a little bit of a cough, right? Those things get overlooked every day because your nurses are dealing with bigger fish, right? They're dealing with staffing issues. They're pitching in where they need to. And they don't have time or energy to deal with the smaller clinical issues because they're dealing with big clinical problems, right? With RealTime will look at that EMR, pull that data, and say, the nursing assistant documented a little bit of swelling. Not a lot of swelling, just a little bit of swelling in that ankle. And the nursing assistant documented a little bit of a cough. And we can tell from the data mining system that the resident has a diagnosis of CHF. You put those three things together and you have a problem brewing, right? And you can either deal with it on Monday, when the nursing assistant first identified just those little symptoms, right? Or you can wait until Thursday, when that resident is hacking and her ankles look like this, and now, what option do you have? Swollen ankles, hacking cough, and a diagnosis of CHF, what option do you have? Ship them to the ER, okay? Now, let's set aside the fact that that's an expensive place, right, for a Medicare beneficiary to be. It's also a crummy place for an 85-year-old long-term care resident to be. When I was in college, I was a nursing assistant. I was an orderly at the Johns Hopkins Hospital emergency room, right? Now, those of you are y'all from Missouri, right? You probably think, ooh, Johns Hopkins, right? The finest medical institution in the world, blah, 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 all this reputation, right? It's also in a terrible section of Baltimore. We're talking knife and gun club every night, right? Baltimore is not the friendliest of cities, right? And so here you've got an 84-year-old with CHF, a cough, and some swollen ankles sitting in the ER right next to the knife and gun club that's rolling right through, right? They don't have time and energy to take good care of that resident the way you all do, right? So anything we can do to avoid that hospital utilization is really very valuable from a quality perspective to that resident. Right? So we use the electronic data mining system to identify early on that there might be an issue. Then that identifies that for the nurse practitioner. The nurse practitioner pays a visit, walks down the hall, and sees Mrs. Jones, right? Looks at her swollen ankles, listens to her cough, and all that nurse practitioner has to do is say, I think you're retaining a little bit of fluid. Let's increase your Lasix from 10 milligrams to 20 milligrams, right? Drain that fluid off, the cough goes away, the swollen ankles go away, and you've just avoided a devastating hospitalization to that resident, and you've saved the Medicare system, what do you think? $20,000? $25,000? Because you know what happens next? You send them to the ER, right? They start poking and prodding at them. A 25-year-old physician in training comes in, and do they see your 84-year-old Mrs. Jones as a human being? No, they see her as a science project, right? And so they want to poke and prod and take a dozen lab tests and do all the diagnostics they possibly can. And they want to start messing with her diabetes, right? Not just deal with her CHF, they want to start messing with her diabetes because they think they know better than you do, and they don't, right? So our whole goal as a system is to identify those flare-ups of chronic disease early on using the data mining, and then have the nurse practitioner in place knowing your residents so well that nurse practitioner can do interventions that prevent that hospitalization. Right? That's quality. So we talked about the nursing staff, right? The nurse practitioner and the RN care coordinator. So number one, we've improved quality by adding a nurse practitioner and an RN care coordinator to your building. Okay? Number 2, we've improved the quality of care in your building by short-circuiting those did you know questions, because you will know. Every hour, that real-time system is digging into your EMR and pulling out that important data and sorting out the unnecessary stuff. All right? And the third beautiful thing about a provider-sponsored iSNP is revenue. All right? We can help improve the revenue to your facility. So to start with, now these are the long-term care residents of your facility. These are not the rehab patients that are coming in from the hospital and going home 2-3 weeks later. These are the long-term care residents, right? How many of you have greater than 80% of your census is permanent long-term care residents? Yes, 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 okay. And of that 80% that are long-term care, how many of them are, let's say greater than 80% of those are Medicaid also? No? 60% Medicaid. 50% Medicaid. All right, that's a pretty low Medicaid census. Usually I get right in that 75 to 80% Medicaid. This is a way to improve revenue to your facility by supplementing either the private pay rates that you're getting for those long-term care residents or the Medicaid rate that you're getting for those residents. So that the iSNP health plan gets a capitation rate from Medicare, and then the iSNP pays the facility every month upfront a capitated payment. We also make payments to you for supplemental benefits like transportation and attendant services. And then when you reduce cost, right, like saving that $25,000 hospitalization, that becomes a bonus back to the facility at the end of the year. So we're improving revenue all year long and then a bonus at the end of the year. And then, of course, there's the savings that you get, the additional revenue that you get, because you're no longer losing the revenue as you ship that person off to the hospital, or taking the risk that they might be discharged to a different facility. All right? So those are the 3 ways that we can really help in the midst of this nursing shortage. Our clinical model goals, we've talked about optimizing member health, function, improving quality of care, early identification of the treatment of acute changes in condition, improve communication and education to the patient, to their family, and to your staff. Our nurse practitioners are trained in that communication so that they can train your staff on how to do a better job listening to lungs, right? Improve their assessment skills. They talk to, part of their job, part of the RN care coordinator's job is to communicate with the hospital if a member does have to go to the hospital. Communicate with the family, communicate with the DME provider. Coordinate all the various things that a resident may need. So our clinical model of care surrounds that member. There's the RN care coordinator at the top. I'll use my pointer here. The RN care coordinator at the top, the nurse practitioner. We also have member services coordinators, your facility care team, family and staff education. We talked about your EMR in concert with the data mining system. It also is a prescription drug plan, and we manage all the transitions of care for our members. All right. So the nurse practitioner, what is their role? They're there every day. They assess the members at the time of enrollment. They do a complete health assessment. They're integrated with your care team. right? They're part of the care planning team. They conduct what we call lightning rounds, which means they see every member of the health plan every day. They go in and just eyeball them, just check in with them, just build that relationship with them, right? When there are issues, they assess, treat, and adjust the treatment plan as necessary. I talked about managing the transitions, provide clinical feedback, training. There's never seems to be enough time to get all the training done, right? These nurse practitioners are available to you in your facility to do those trainings on clinical issues, right? Post-acute chart audits, and they are on call 24/7. The RN Care Coordinator, again, integrated with your clinical team, also conducts lightning rounds, assesses members who are at risk, coordinates that care plan with the nurse practitioner, coordinates that care plan with your team, the PCP, and any outside specialists or providers. They're the ones who are reviewing the ongoing goals of care, advanced directives, and directing the nurse practitioner as to where the opportunities are. Collaborate with the benefit services team to make sure the resident is getting all the benefits they need and deserve, and then reviewing with the hospital the plan for discharge. So one of the keys is communicating with the hospital, right? So when you do have to go to the hospital, I've talked a lot about avoiding hospitalization, but when you do need a resident of yours to go to the hospital, they need to go to the hospital. And the nurse practitioner is there to communicate to the providers at the hospital. The RN Care Coordinator is there to communicate with the nursing staff at the hospital, what the patient needs, what the resident needs, and then if they do get admitted, what their discharge plan would be, all right? Because we're a Medicare Advantage plan, we can also offer what are called supplemental benefits that are a benefit to the facility as well as to the member, right, in this nursing shortage. So certainly dental, over-the-counter catalog, vision, hearing, podiatry are all extra benefits that are provided through Medicare Advantage. But what's interesting on this side of the circle there are companion support, health aides, and non-emergency transportation. So there's a transportation benefit that we can pay you, the facility, for your transporting that resident, right, to one of their specialty doctor appointments. And when you do that, how many of your residents can go to those specialty doctor's appointments unaccompanied? Not very many, right? And so if the family isn't available to go with them, then you have to pull somebody off the floor to go with them. You're already short-staffed. Every one of you told me that, right? So pulling somebody off the floor for 3 or 4 hours to accompany a single resident to their cardiology appointment is a significant burden, right? The iSNP has, I used to call them escort services, and that had a whole different connotation. So I'm not allowed to say that anymore. They have health attendant benefits, where we will pay, right, for a nursing assistant or health attendant to accompany your resident, our member, to those specialty appointments. It can be a member of your staff working an extra shift, we can pay for that, or we can coordinate with an outside agency to bring them in and accompany them, so that you don't have to pull somebody off of the floor for that shift. There we go. Okay, let me talk for a minute about improving the revenue in your facility, and the idea being that if you have more dollars in revenue, then you can afford to pay your staff more, to be more competitive, to hit your your margins, if I remember correctly from my not-for-profit days, no margin, no mission, right? And so this is an opportunity for an institutional special needs plan to contribute to the revenue of the facility. So let me just talk to you quickly about how the I-SNP financial model works. And there are other I-SNPs other than PPHP that have similar models. Everybody has a little bit of a different twist on it, but they basically work the same way, right? Start out with Medicare, CMS, pays the health plan, in this example, about $2,200 per member per month. And right off the top, we pay the facility $530 per member per month. Okay? And then PPHP, the I-SNP, incurs all the other costs for the Medicare benefits that long-term care resident incurs. So if they go to the hospital, PPHP pays those claims. If they go to the doctors, PPHP pays those claims. Right? And the Part D drug benefit, PPHP pays all of those claims. In addition to that, included in what's called the medical loss cost or the medical benefit cost is the cost of the RN care coordinator and the nurse practitioner. So all of this is included, right, in the cost. And we add all that up on an annual basis and come up with a per member, per month medical loss ratio. And in this example, that medical loss ratio is 79%. So you've got the capitation payment to the facilities. You've got all of the claims costs. That's about 40% of the Medicare dollar, right? Then you have the care management costs. They're at 15%, which is the cost of the RN care coordinator and the nurse practitioner. And that, in this example, adds to $1,738, or 79% of the premium of $2,200 that we're paid. Right? The way our risk program works is the facility receives a bonus for having a medical loss ratio that's less than 85%. Remember, 85% is the Affordable Care Act benchmark. So if, by virtue of our early intervention with our nurse practitioner and RN care coordinator, right? If by early intervention, by virtue of our data mining system, we are able to lower the incidence of hospitalization and have savings against that 85% benchmark, that savings, in this case 6%, or $132 per member per month, is paid to your facility. Okay? And then there's an administrative portion of the benefit cost for processing claims and doing all the CMS compliance work, and that's benchmarked at 15%. So, the green pie, does that look green to you? My children are always telling me I'm colorblind. Right? I think I can see that. The green is the portion of the Medicare dollar that accrues to the facility. Right? The blue is the cost of care management, and while that isn't directly revenue to your facility, that is the cost of those additional nursing staff people in your facility. So they're providing real hands-on care to your residents. Right? Then this big quadrant there, or big piece of the pie there, is the other medical claims that we talked about: hospital, doctors, DME, etc. And then this purple piece of the pie is the admin cost. Okay? So what does that mean to facility revenue? Because remember, I talked about how we can help in the midst of a nursing crisis. One is to add nursing staff, a nurse practitioner and an RN care coordinator. Two is to bring data mining into your EMR so that you can know what's going on with your patients and focus on where the trouble points are. And three is to improve revenue. So in this example over here, right, our benefit cost is at 79%. That's $1,200 per member per month. That leaves the building revenue at $662 per member per month. If you have 70 members in your building, that's new revenue of $556,000 a year. Okay? That's a significant bump in revenue for you and your facilities. All right? So, additional clinical staff, data mining, additional revenue. Those are the ways that a provider-sponsored institutional Medicare Advantage plan can help you improve the quality of care in your buildings. And with that, I'm going to stop talking for a minute and see what questions you have. Nobody has any questions?
So you have to have a minimum of 50 residents in your skilled unit to make this work?
No. So the question is, do you have to have a minimum of 50 residents in your facility to make this work? You really don't. If you have fewer than 50 residents in your facility that sign up for our program, right, then we would reduce the number of hours that the nurse practitioner was there every day, right? But the nurse practitioner would still come several times a week and be engaged in your facility. If we got down to, well, there are really only 10 residents in your facility or 15, then what we would probably do is work with your primary care provider, right, and give your primary care provider additional incentive to spend more time with those residents in your facility. Okay? Other questions? Yep.
So is the real-time software, is that unique to something that you all do, or you're able to pull that information?
So the question is the real-time software unique to what we're able to do? So RealTime is a proprietary system that is owned by the same people that own the health plan. They're separate entities, but they're owned by the same people. So if you contract with PPHP for our iSNP, then we use that tool as part of what we do. You can also contract with RealTime separately, and they have another whole economic structure that they can, without PPHP, you can contract with them separately. And they bring benefits to the table, such as they're able to evaluate PDPM for your post-acute patients and make sure that you're maximizing and accurately reflecting the real cost, the real factors that go into the PDPM rate. They've got lots of other interesting ways of helping long-term care and post-acute facilities, but the specific part of it that the health plan uses is that monitoring of the EMR.
So that integrates, so we have Matrix Care, that would integrate with Matrix Care to pull that information out?
Yes, so let me not use the word integrate.
Okay.
I wouldn't say that RealTime integrates with anything. What I would say is RealTime goes in and simply pulls the data out, okay? Because the PCC and and Matrix Care. Actually, Matrix Care is pretty cooperative. PCC is pretty not. But it's not a request for PCC or Matrix Care data. It's your data. It's your patient's data, right? And all RealTime does is go in and mine that data out, and then it does its own analysis and reporting of it. Okay, and really the way both of these companies came about, right, was through the frustration of a long-term care operator in Maryland and Pennsylvania who wanted some simplified reports out of PCC and couldn't get them, and so he started his own company. Wanted a health plan that would pay the nursing home for the real care that what they were providing, and Optum and Cigna weren't willing to do that. And so because our owner, Dr. Scott Rifkin, is sort of a serial entrepreneur, he launched these two companies. Other questions? There's my contact information. And then Paige is our partner development person here in Missouri. We have a partnership in every state where we do business. We have a partnership with a long-term care post-acute facility operator. And so here in Missouri, it's our friends at HSI. We have a partnership in Maryland, one in Pennsylvania, one in Texas, and one in Illinois, in Chicago. So if you are part of an organization that has facilities outside of Missouri and want to talk more about taking this kind of a provider-sponsored health plan to the state where you do business, I'm happy to talk about that too. We are always looking for new partners. Other questions? I'm going to get you out of here 15 minutes early. That's the best thing I could have done, right? All right, thanks very much.